Thanks. I'm actually not very extroverted, except sometimes in front of obstetric anesthesia audiences. So I was asked, sort of repeating what Ken Nelson said, I was asked to give a talk on sepsis in the obstetric population by Callie, and my first question was, why me? Because I really don't know that I know anything about it. But as Callie said about the whole Suboxone and drug abuser population, it gave me a chance to learn something about it. So let's see if I can make it a little clearer what there might be, what might be involved. I'm a consultant for a company that's designing some new epidural needles, which has nothing to do with this talk. So I'm supposed to talk about objectives, and there are really three, and they're pretty simple. And in fact, the take-home message from this talk will be fairly simple. We'll discuss the incidence of maternal sepsis or obstetric sepsis, a little bit of contrasting it with the United States and the rest of the world. If I just say this next sentence, you'll know it. Understand that the incidence does seem to have increased in the past 2 decades, probably by about 100%. So it's roughly doubled in the last couple of decades for reasons that aren't completely clear, but now you've gotten one of the objectives done. And maybe, although I doubt it, we'll all understand the differences in causes and presentation of sepsis in pregnancy versus non-pregnant. But I will go into why there's interest in how sepsis is different in its manifestations and diagnosis in pregnancy versus the non-pregnant population, and in outcome, actually. And the outcome probably is a little better in pregnancy. So why are we talking about sepsis? After all, this is not 1865 when Semmelweis died. We kind of know to wash our hands now, most of us. And the incidence, frankly, and this is another important take-home message, we're going to talk about sepsis for the next 20 minutes, 25 minutes, but the incidence of septic death is about 1 in 100,000 pregnancies in the developed world. So let's not go crazy. It's still low. It's not good, but 1 in 100,000 is not the biggest public health problem in the world. But it's still common enough in the developing world, and it's rising, as I said, in many parts of the developed world. And there's some intriguing evidence that it's different in different countries. There's a lot more morbidity than mortality, so while I can easily brush off 1 in 100,000 and say, well, you know, why worry too much about that? The incidence of significant morbidity may be an order of magnitude or 2 orders of magnitude higher than that, 30 or 50 per every death. It may be that the immunocompromised state of pregnancy contributes to the development of sepsis from things that wouldn't cause infection and sepsis in other patients. And this is one of the key points that people are at least making in the literature. It may be difficult to diagnose early sepsis in pregnancy. And that's something you should at least keep in mind, because if for no other reason, then it will be talked about a lot, so you might as well know what people are talking about. It may be the leading cause of maternal death, but again, to get back to reality, no matter what we do, there will always be a leading cause of maternal death. Even if it's 1 in a billion, that one is going to be the leading cause. So when you see headlines like something is the leading cause and this is terrible, you need to look at the numbers, because there'll always be a leading cause of everything. So as I said, why me? I really wasn't sure, but then I got required to take some exams because the governor of the state of New York, where I live, has decided, I don't know if you can read this, but I love what it says, New York announces New York State to lead the nation in fighting sepsis. So that's why I'm here, because I am at the, one of the larger private universities in New York, and we are leading the nation in fighting sepsis. What this means is we had to take a bunch of online exams. Okay. So this is what we'll talk about over the next 20 minutes. We're going to define sepsis and septic shock, and that's been done by other people before me, and I'll just copy their definitions. We'll talk a little bit about the epidemiology of sepsis in the obstetric population worldwide, and a little bit about that issue of how to recognize a septic patient in pregnancy. So most of you have probably seen this, but just to go over it, because we will refer to it later, there's a syndrome, if you will, called SIRS, Systemic Inflammatory Response Syndrome. You've all heard about that, I assume. And it involves basically some factors. These have been defined by the critical care people for the last 20 years, and they've been redefined, and they've been relooked at and have not changed in the last 10. So a temperature above 38 or less than 36, heart rate greater than 90, respiratory rate greater than 20, or a PCO2 less than 32, and a white blood count above 12,000. Those of you who have ever looked at the lab tests on a pregnant woman will realize suddenly that a lot of pregnant women have SIRS. And probably they do. And probably labor is an inflammatory syndrome. So again, if you want to leave now, basically this is part of the lesson here. It's difficult to tell when a pregnant woman has SIRS from sepsis because she's got it from being in labor. Or even from being pregnant. I mean, the CO2 less than 32 is fairly normal. White counts go up in pregnancy. So you can get and heart rates go above 90. So you can be pretty close to these SIRS criteria by just being pregnant and certainly by being in labor. So again, that's one of the key points. It can confuse the diagnosis. The definition of sepsis, according to these criteria from the critical care people, is SIRS with infection. How do you know if someone's infected? Well, it's kind of a roundabout thought process, because most of the time we think they're infected because they have SIRS, and we don't know what else it could be. But sometimes it's obvious they're infected. Severe sepsis is sepsis with organ dysfunction, hypoperfusion, or hypotension. So sepsis with effects on some evidence of organ perfusion. And septic shock basically is severe sepsis without a good response to the initial therapy. What did I do? Okay. So again, I kind of alluded, maybe not properly or too humorously, to the magnitude not being very severe. Obviously, it's very different in the developing world. Sepsis probably accounts for about 10% of maternal deaths in both the developing and developed world, but of course there's about a 10 to 100-fold difference in the absolute number in those two places. In South Africa, which you might think might be sort of halfway between the least developed world and the most developed world, sepsis probably accounts for about 9 deaths in 100,000. So again, about 10-fold more than here. There is some thought that it has to do with increased institutionalization of birth in the developing world. I'm not so sure of that. I don't think, when the births are happening, outside of hospitals, there may be plenty of septic deaths we don't know about at all. So while in the 19th and early 20th century, moving births into hospitals increased septic deaths from carrying germs from one person to another, I'm not sure that's a big factor here. The etiology is pretty much what you expect: pyelonephritis, chorioamnionitis, endometritis, although in the one series of ICU patients, pneumonia was a big cause of sepsis in the obstetric population. The bugs involved, beta hemolytic strep is the big one, E. coli is the next. There is some evidence, and I'm not going to go into what that evidence is, that these bugs are getting more virulent in the last 10 years. Whether it's antibiotic resistance, whether it's been just selection of various bugs in different populations isn't clear, but the response to therapy is somewhat less good in all patients, not just pregnant patients, than it was in 1995. Is the data on this any good? When you have 1.5 septic deaths a year in the Netherlands, how good can the data be? Because if they miss 2 cases, then their rate is 3 times what they thought. So you need to take all of this with a little bit of a grain of salt or half a shaker of salt. As I said, though, in the Netherlands, there were 39 cases of what's called severe associated maternal morbidity associated with sepsis per year. So again, about 2 orders of magnitude, or an order of magnitude and a half, more morbidity from sepsis than mortality. So the morbidity data probably is a little better because there are more cases to follow. It covers about 10% of the obstetric admissions to ICUs. The interesting thing about the data is if you look at a bunch of, these are all European countries, either this is interesting or it shows us how the data may not be believable. What you see here is in Belgium and Norway, the rate of septic death, or sepsis cases actually, is 8 times that in France and Hungary, or 10 times that in Italy, or 10 times that in the UK. It's possible. It's also possible the reporting is just very, very different. And you need to be careful, and I try to be careful about believing low numbers. This probably is a little better data because it's all from one place, from Aberdeen, Scotland, and it confirms what people are talking about. If you look at the orange line is I can't read it. I think it's sepsis cases. And what you can see is after a decrease in the, let's say, the 80s, a real increase was when we get to the last decade, probably a doubling or tripling. The red line is severe sepsis, or is it septic death? I'm actually sorry, I actually can't read it. But it does look like there's been an increase in the last decade. So this is data from Aberdeen, Scotland, one city. Similar data was reported by Melissa Bauer and colleagues in a study looking at the national inpatient sample, which is, I think most of you know, about 20% of hospital admissions in the United States. And the incidence of sepsis was 1 in 3,000 pregnancies. The incidence of severe sepsis was 1 in 10,000 pregnancies. Again, so you're going to see these occasionally, obviously, if you have delivery services of 2 to 5 to 8,000 per year. And septic death was 1 in 105,000. This number keeps coming up. So again, if you want one lesson from this, whether you, I don't know if you care about it or not, but 1 in 100,000 keeps popping up. It'll pop up again once or twice. The incidence of sepsis appeared to be stable over the last 20 years, at least in this study in the United States, but the incidence of severe sepsis and septic death seems to be increasing by 10% a year, and so has roughly tripled or so over the 20 years. Again, why is not clear, because doesn't seem to be more sepsis. Maybe the infectious agents are worse. Well, theoretically, the treatment could be worse too, but I don't think so. This is Melissa's data, and basically what you see is sepsis here, pretty stable, severe sepsis rising, and septic death rising a bit more. The risk factors, and you'll see another slide like this from a different study, and most of them are similar in the two studies. Older age is bad. Being African American, in every obstetric study of every possible complication seems to be bad, whether that's bad care or something inherent to that population isn't clear. Being on Medicaid is bad, again, whether that's the population or whether it's bad medical care isn't clear. Having retained products, premature rupture of membranes, having heart failure, other organ failure is not a good thing to start with. It's a risk factor for septic death. And having a C-section emergently is not good, but having it electively is actually protective. So obviously we're moving in the right direction on that one. Sepsis also occurs here in California. A lot of things supposedly don't, but this one does. California vital statistics and discharge data for a 3-year period, and there were 1.6 million births, and what you'll see if you look is 14 deaths, which gives you about a 1 in 100,000 death rate from sepsis. So that's your number. That's about the most solid number we can find. The risk factors in this study were pretty similar, being greater than 25, less education, no health insurance or public health insurance, the same sort of thing. C-section again, especially emergent, and basically having diseases. Now this is a little bit different data, but just to show you what I mentioned before, I'm not sure why I didn't put this slide earlier, but this is the death rate from infection or sepsis in the United Kingdom. So here we are back in 1865, and here we are now at 1 per 100,000. And as we know, Central Africa is still in 1865 when it comes to infection. So the truth is, if we want to do something about maternal deaths from sepsis, we probably should be going to Africa. In fact, I do a little bit of that. The problem is not confined to pregnancy, of course. This is just to throw it in there as far as epidemiology. Here's the incidence of sepsis in the non-pregnant population, and you can see septicemia. There's, what are the differences here? I can't remember. Septicemia, well, you can see it's rising. I actually don't remember what the two different colors are. Sorry about that. Why are pregnant women at higher risk? Well, we talked about some of this. They do undergo some tissue disruption during birth, although, as we know, it's a natural process. There are procedural risks with C-sections, et cetera. And maybe, just maybe, the SIRS of labor masks the SIRS of infection. On the other hand, they start off young and healthy, so fewer die, so the data is less reliable. Now, here's an ICU case series. What am I doing? Okay. ICU case series from Bahasa in Tennessee, I guess. And it's a retrospective chart review of 15, 16 years in their hospital of 30 pregnant women who were hospitalized in the ICU with sepsis or septic shock. So this is a very selected population. It's a referral center. There aren't too many of these series, but I will say from the outset, it's hard to know what to make of this when it's a referral center that got women who are clearly diagnosed with sepsis and have to be in an ICU. But there may be 1 or 2 little pointers that you can get from this. Number one, again, pyelonephritis was a big cause of sepsis in obstetrics. Pneumonia was the next most common, and the rest are all fairly low incidence, but the kinds of things you might expect. None of these women, I think, had chorioamnionitis, which is interesting. It may just mean that's a milder form and doesn't get to the ICU. Nothing very exciting here that I think you can learn, except that, and this is maybe trivial, the patients with severe sepsis did better than the patients with septic shock. I don't think that should be a shock to anybody. And the deaths all occurred in patients with septic shock. Again, not too surprising. The one thing that came out of this, and it has come out of other surveys of pregnant women who end up in ICUs, is that you can't use the usual scoring systems for ICUs, the Apache scores and the various multi-organ system failure scores, to try to predict outcome. Because failure in greater than 3 organs tends to predict death in ICU patients, but it doesn't predict death in this population or in other obstetric populations in the ICU. Exactly what to do with this information isn't clear, but it probably means don't give up. That pregnant women will often, because they're young, because they're pregnant, who knows what, will often come back from what would otherwise kill somebody else. But failure in 3 organs did not predict mortality at all here. And in fact, and hopefully you will be able to follow my logic on the next few slides, because it's an intriguing, well, I think it's intriguing to think about this issue. This is a quote from the paper. In our patients with septic shock, there was no progressive deterioration of hemodynamic and laboratory variables, but instead, there was a rapid decompensation in those who died. Indeed, all 3 women who died had multi-organ failure at transfer to our tertiary care facilities. I think that may be an excuse, like we didn't kill them, someone else did. This has important implications for patients managed in non-tertiary, which I don't think is a word, centers, and/or by physicians in medical ICUs not familiar with the physiologic changes in pregnancy. It emphasizes the need for early diagnosis and initiation of aggressive goal-directed treatment of severe sepsis, septic shock, in a center familiar with the unique needs of pregnant postpartum women. So this is part of what's in the literature, part of what we're being told, that pregnant women are different in some way and need to be thought of differently. And it's probably true, but I'm just going to, I think, in the next 2 slides, I'm going to skip this, actually. After this slide, I'll get into this argument. So we talked about why is the rate of sepsis increasing? Is it better diagnosis now? Possibly, now that we have criteria. Is it worse treatment? Probably not. Is it better detection? I think that's the same as better diagnosis. Is it stronger bugs? I talked about that. The diagnostic issues, as I said, pregnancy physiology may mimic the sepsis criteria. So we might miss septic women because we think they're just pregnant or just in labor. It could also lead to overdiagnosis if you assume everybody with a heart rate over 105 is septic. Pregnant women are healthy, therefore they're going to have lower morbidity and mortality and maybe tolerate being sick better. But here's something I just want to leave you with, not leave you, almost leave you with, that may be confusing. I hope it's confusing to you because it is confusing to me. This comes from the exam I had to take online from New York State, because I had to take both an adult and a child exam, not because of neonates, but because some pregnant women are under the age of 18. Children and neonates, this is a quote from a paper, but they said the same thing in the exam. Children and neonates maintain higher vascular tone than adults. Therefore, the shock state occurs long before hypotension in children, okay? Sort of makes sense, maybe there's data for this, maybe not. Okay, just want to point out, people say the same thing about pregnant women, that the shock state happens later. But of course, pregnant women have lower vascular tone. And shouldn't they become hypertensive earlier and declare their sepsis sooner? But they don't. So I'm just going to, again, this is more confusing than anything else, and I hope it's confusing to you, because it does seem that the same argument is being used. Children have high vascular tone, therefore they hang on longer before you see their septic. Women have lower vascular tone, so they hang on longer before you see their septic. It doesn't make sense. And that's, as I said, I don't know if I ever titled a slide, not sure I understand the logic before, but I don't. Now this is an interesting study. This is a fun one too, that basically tells us we don't know what to do. This comes out of Northwestern. I'm sure Cynthia is very familiar with this. This is a retrospective study done by the obstetric group, by the maternal fetal medicine group, of all patients with chorioamnionitis over 18 months. And they defined it in the usual way. They found about 1,000 patients, or 900 patients with chorio. And what they did is they looked at the data in the chart and they gave them a SIRS score and a MUSE score. MUSE is Modified Early Warning System. There's now been a further modification for obstetrics called MEOWS or MOAs. But basically they tried to see whether these scores would predict who got really sick, like went to the ICU or died. And so the criteria for saying that the SIRS score is high enough to cause problems or very well established in literature, as with the Muse. And these are, we don't have to spend too much time. These are the scores I talked about before, the SIRS score. The Muse scores are a little different, but basically involve heart rate and respiratory rate and temperature. So they're basically two different ways of assessing how sick is the patient. Now, when they looked at this, and I'll try to simplify this by just looking at one thing. Basically, if the question is, if someone has a bad Muse score or a bad SIRS score, how likely are they to really be sick, need the ICU, or have a major clinical event or die? The answer was, if you had a positive SIRS score that should indicate you're pretty sick, you had a 1.7% chance of really being sick. Sorry, the SIRS is down here. And if you had a positive Muse score, you had a very, very low chance of really being sick. So these two scoring systems were atrocious for predicting who was really sick. So do we know how to predict which pregnant woman is pretty sick, who has got a heart rate of 110, the blood pressure not so great, and the CO2 is low because it started low? The answer seems to be we don't. That's a great conclusion, isn't it? Anyway. So again, another way to look at the data is, in the original modified early warning system scores, scores of 3 or 4 or 5 or 9 were associated with a 12.7% chance of a real clinical event, or if it was 5 to 9, a 30% chance of a clinical event, which is, again, a pretty serious thing, like intubation or ICU transfer or death or a major complication. So in non-pregnant populations, essentially, this is relatively good. The score is 3 or 4, is a 10, 15% chance this patient's really sick, so you might want to act on that. In this cohort, those numbers are 0 and 2.3%. So these scores, these assessments, don't work in pregnancy. They probably work even worse in labor, per se. So Muse does not predict outcome or reflect pathology in pregnant or postpartum women. So what do you do for sepsis if you think it's there? Now that I've told you you can't possibly diagnose this, and it's pretty rare anyway. Well, what you do, these are recommendations from the Surviving Sepsis, not committee, but I'm not sure what C stands for, but Surviving Sepsis, what does it stand for, Lawrence? Campaign, I'm sorry, yeah, I forgot. Surviving Sepsis Campaign is just blocking on that. And they're pretty basic. But the things you should remember, and this probably will be used more outside of obstetrics than in it, is a serum lactate level is recommended to be drawn very quickly. Basically, it's a way of following the patient and assessing whether it's septic shock yet. Blood cultures should be done prior to antibiotics. Broad spectrum antibiotics should be given essentially right after the blood cultures are drawn. If there's a decreased blood pressure or lactate's high, you start with fluids fairly aggressively and then add vasopressors as needed. And if that's not quite looking right, you put it in the CVP and titrate to over 8. And for a venous saturation over 70. This has been shown to decrease mortality. It's pretty basic stuff. It's stuff we've all been doing for a while. By protocolizing out like this, it actually seems to have helped. Of course, it's never been validated in pregnancy. And, you know, I've spent the last 20 minutes telling you pregnancy is different, but I think this is obviously what one would do in a pregnant woman who unsuspected sepsis. How do you prevent it? Well, you can wash your hands. That's always a good idea. Intravaginal antiseptics have been talked about for various procedures. Prophylactic antibiotics at C-section before incision have been shown to decrease sepsis postpartum, and perhaps for ruptured membranes a little more often than we now do. So in summary, sepsis and its severity are increasing moderately overall over the last couple of decades. The incidence is still fairly low. I don't expect it to jump up by a factor of 10. Early detection is very difficult. So these patients who are getting very sick are actually a little bit hard to figure out. The protocols to treat these women are similar when diagnosed, perhaps with slightly different endpoints, because the hemodynamics that we follow will be different in a pregnant woman. And I think that's about it.